Okay, team, if this recording seems a little different than normal, one of the reasons is because my iPad decided to quit recording the last time I taught this. So we're going to try this again. So we've already talked about prerenal AKIs, meaning that this is where you have hypoperfusion into the kidneys, causing an AKI. Now, next we're going to talk about intrinsic AKIs. And if you remember in our definition of prerenal AKIs, we said this was without parenchymal damage. Once we move into parenchymal damage, so that could be because of prolonged prerenal or because of a nephrotoxin that causes parenchymal damage, that's whenever we get intrinsic AKIs. When we talk about intrinsic AKIs, we're going to talk about the pathophysiology, the etiologies, meaning the causes, the patient presentation, and the treatment. Now, there are several different types of intrinsic AKIs. Most common is acute tubular necrosis, also known as ATN. Then you have vascular and interstitial disease, and then finally glomerular disease. Because this is so rare, glomerular disease, I'm going to hold off on teaching you guys about it. If you guys ever go into residency, if you ever have a renal rotation, you can learn more about it. But let's just focus on acute tubular necrosis and vascular and interstitial disease. Specifically for vascular and interstitial disease, we'll talk about acute interstitial nephritis. And then for acute tubular necrosis, we're going to talk about two different types of acute tubular necrosis, ischemic ATN and nephrotoxic ATNs, with our nephrotoxic being either endogenous or exogenous. So, ischemic ATN is really a prolonged prerenal AKI, or hypoperfusion. So if you remember back here, I was talking about how prerenal AKIs are AKIs without the parenchymal damage. Well, if we have a prolonged time of prerenal AKI, it can transition over to an intrinsic AKI. So prolonged hypoperfusion can lead to parenchymal damage and cause an intrinsic AKI. Lucky for us, we just spent a lot of time talking about how to treat a prerenal AKI. So we know prolonged prerenal hypoperfusion can lead to it and how to treat it, because we just know that we need to just take care of the prerenal causes. Next, you have nephrotoxic ATNs. So these can be either endogenous or exogenous nephrotoxins. We'll talk about each of these here in a moment, but let's first take a step back and talk a little bit about ATN's pathophysiology. So the pathophysiology of ATN falls into four different phases: initiation, extension, maintenance, and then recovery. So in the initiation phase, you really have your initial insult. In the extension phase, the injury will extend into the tissues around it, into the interstitial space, due to hypoxia and an inflammatory response. Also, at the same time, because of the damage, cellular debris will accumulate and actually clog up the tubules and cause a decrease in your GFR as well. In the maintenance phase, this is where the GFR reaches the nadir, and this can take multiple days, but we'll spend a lot of time with low GFR as our body starts doing the cellular repair process in an attempt to reestablish normal cellular polarity, integrity. A lot of times during this phase, you might see that the patient is non-alleluric, and actually could be diuretic because you're having a high urine output, because you're waiting for the cells to actually become the official renal cells. So in that time, while they're immature, they'll just pretty much not work right and not have the correct amount of polarity, and will continue to just dump fluids. And then finally, recovery. New tubule cells are regenerated through redifferentiation, and epithelial polarity is reestablished. So this is where we'll go back to normal, at least hopefully. So I've already talked a little bit about ischemic ATN, that's that prolonged or prerenal ATN, and it also can be due to multi-organ damage such as sepsis. Let's talk a little bit about our nephrotoxic ATN. Now, there are two different types of nephrotoxic ATN. You have endogenous, meaning that this is caused by things within the body. And exogenous, you can think about this as medication related, or toxins that are outside the body. Here you have aminoglycosides, radioactive dye, amphotericin B, cisplatin, and vancomycin. So for endogenous, it can be caused by multiple different things, including like hemolysis that causes free iron radical formation, tumor lysis, and myelomas. But we're going to really focus on rhabdo because rhabdo has a lot of treatments for it, and it is probably the one that you will see the most. So let's talk a little bit about what rhabdomyolysis is. Now, you guys maybe have heard of rhabdomyolysis, especially when we talk about the drug-related causes with fibrates and statins. So, also this can be caused by other things, such as people who have a prolonged time where they are down, like old people who've fallen and they can't get up, and they have an injury where they have muscular hypoxia due to limb compression. Also, this can also be due to overexertion and exercise. So the two normal ways I see this occur is like an old man who decides that it's his time to shovel his walkway, maybe a snowblower broke, and goes outside and overexerts himself, comes back inside and has coke-colored, or next morning wakes up with coke-colored urine. And then the other one is, I've seen patients that come in with like young men who used to be football players, typically, who decide that they can weight lift. One day decide in the middle of their college time that they can weight lift like they did back in high school, and will overexert themselves and cause a rhabdomyolysis as well. So as far as our pathophysiology here, what occurs first, and like some of the other drugs that we've talked about that have multiple mechanisms, this has multiple mechanisms. First, you have separation of fluid from the injured muscle. So this actually causes to go into the circulatory system and causes like third spacing, and this is going to cause hypoperfusion. At the same time, these myoglobin cytotoxicity or myoglobin cells will be released, and they can actually cause free iron direct toxicity within the kidney and cause a specific parenchymal damage. So you can see that this has some pre-renal components, but this right here makes it the endotoxin. So how does this present? Probably if there was one thing you should get from this slide is CK or creatinine kinase. You'll check it and it will be at least 5 to 10 times the upper limit of normal. And there's your upper limit of normal. Or this is your normal. Now other things you may see, tea-colored urine or coke-colored urine. Urine positive for myoglobin. Electrolyte disorders including increases in serum potassium and phosphorus and magnesium with decreases in serum calcium. And then you'll also see that these patients will have a history of recent trauma, immobility, and exertion with muscle pain and weakness. As far as the treatment, the big thing here is that we want to flush out the kidneys. So you'll see that we'll do hydration, titrating to a urine output of 3 mils per kg per hour, or 200 to 300 mils per hour of urine output. Now, if this fails, we can try urine alkalization, which has some questionable efficacy. So we will be titrating to a urine pH, and it's notable to say urine pH, of greater than 6.5 to 7. And we do this using sodium bicarb. It is notable that whenever you give sodium bicarb in fluids, you do not want to use normal saline. You either use half normal saline or D5. Okay, so we talked about our endogenous cause, primarily rhabdo. Let's talk about some exogenous causes. So for each of these, I want you guys to know the risk factors, mechanisms, prevention, and treatment. And you guys will find that the risk factors will tell you a lot about the prevention. Treatment primarily is supportive care. So don't get too in the weeds about some of this stuff, but I'll try to point out what's important. So let's start out with aminoglycosides. Their primary mechanism of renal injury is via tubular toxicity, and they act on the mitochondria to induce apoptosis. At the same time, kind of similar to SGLT2s, they will cause constriction at the mesangial and contraction, and they will reduce renal blood flow through vasoconstriction as well. You'll see that these patients will have potassium and magnesium wasting, and you'll see that potassium and magnesium wasting is a risk factor, as low potassium or magnesium is a risk factor, and having a prevention of avoiding hypomagnesemia and hypokalemia. As far as other risk factors, gram-negative red bacteremia and shock are a risk factor, especially the shock, and that makes sense since shock is a risk factor for AKIs, period. Hyperbilirubinemia, so high bilirubin, and dehydration and poor nutrition. There are some medication-related. You can see that these are mostly dose-related or using concomitant nephrotoxins. You have a trough level of greater than 2, prolonged therapy of greater than 7 days, and a large cumulative dose. You do not need to know the specific trough level or the specific number of days. Just so you guys know, some antibiotics that are aminoglycosides, because I know you guys haven't had ID yet. These are the mycins, gentamicin and tobramycin, and then amikacin. Our next drug is radiographic dye. This is usually iodinated dye. It's used in procedures in order to see the blood vessels, and so that we can know exactly where the blood and well, you also can give it orally, but if there's any extra vascular leakage, or also can tell us where blockages are. So this is used for diagnostic imaging. You see this mostly whenever you give it IV. PO doesn't really cause the same risk here. So, hypotension, acute vasoconstriction, and then oxidative stress are the mechanisms. And really the risk factors revolve around the type of contrast and if the patient has pre-existing CKD. So the type of contrast, meaning that you want to try to limit the volume and then also use lower osmotic agents. If you don't need to use contrast, then you can try to avoid it if possible. You want to make sure you're holding nephrotoxic medications for 48 hours, and giving fluids such as normal saline is appropriate prior to administration, along with N-acetylcysteine. Once again, our treatment really is supportive care. You might need renal replacement therapy. Amphotericin B has gotten the nickname amphoterrible due to its high toxicity, and it's rarely used, but it is used for severe fungal infections. So you'll see here that there are two mechanisms of its injury: direct tubular toxicity via ergosterol, which makes sense because cell walls of fungi are very similar to cell walls of our bodies, and that makes sense why you would have a high rate of toxicity there. And then you can also see afferent arterial vasoconstriction. You'll see potassium, magnesium, and sodium wasting. And the risk factors here are really related to dose and the type of injection, with high dose rapid infusion and non-liposomal infections being higher risk. And so the liposomal injection is one way to reduce your risk. Most hospitals do just use the liposomal injection, so that's pretty easy. Increased age and pre-existing CKD. You can assume that these are greater than 65 years and less than 60 mils per minute. Dehydration, hypokalemia, as it does cause potassium wasting, and concomitant nephrotoxic medications. We once again can use N-acetylcysteine whenever we're using these agents to help prevent your risk. Treatment really is discontinuing therapy and providing supportive care. Next, we have cisplatin. This is an anti-neoplastic agent, so it's a chemo agent. Really how this works is that it, after cellular intake and high accumulation, it causes reactive oxygen species that leads to direct toxicity. Cisplatin has a cousin agent, you can think of it, it's within the same class called carboplatin that has less of a risk. So you do see that cisplatin has a higher risk than carboplatin in these cases. Other risk factors include dehydration, renal radiation, meaning that you're getting radiation in the kidney or around the kidney. And then alcohol abuse. Prevention, you can try alternative agents such as carboplatin, and then dose reduction to decrease the frequency of administration. vigorous hydration, once again, is one of the things we can do. And there is a specific agent here called amlodipine. It does cause hypotension. It is dosed based off of surface area. And then once again, we'll provide supportive care. Our final agent is Vanc. It causes AIN, which we're going to talk about in the next, but it also can develop obstructive tubular cast via various mechanisms. It doesn't really fit as well into the endogenous toxins that we've talked about before, but it is an agent that causes a lot of AKI, so we do need to discuss it. So, like aminoglycosides, there is the agent related, so dose, the AUC, and the trough level, and the duration all play a role. But there's also some patient-specific things, such as the severity of illness, ICU admission, having CKD, and chronic concurrent nephrotoxin exposure, and concurrent Zosyn, or piperacillin, tazobactam. Some ways that we prevent this is using therapeutic dose monitoring, so checking trough levels, and avoiding unnecessary nephrotoxins. Most hospitals will have a policy where you have to monitor their serum creatinine daily. So now that we talked about our exogenous nephrotoxins, let's talk about interstitial nephritis. Now, acute interstitial nephritis is an inflammatory reaction. You can almost think of it as an allergic reaction that goes into the kidneys. And like allergic reactions, it can be caused by a multitude of agents. We're going to focus on the 5 Ps, but it is important to note this. So your 5 Ps are P, i.e. diuretics, PPIs, pain-free, and you can really think about this as Tylenol, penicillin, and rifampin. So the 5 Ps are listed here. Some of the drugs that can cause acute interstitial nephritis are listed here, but I do want you guys to focus on those 5 Ps. Now, why is this important? Or let me just say, there are a multitude of factors that can cause acute interstitial nephritis. I want you to focus on these few because they are the most common, but it can be anything from a patient changing their detergent to an agent like this. But I want you guys to note these. So how does a patient present? This is a rather insidious disease because it can start between 14 to 6 months after starting the therapy. It is not an immediate reaction. And the patients who usually have some nonspecific general complaints, including anorexia, malaise, and arthralgias. They may have fevers and a maculopapular rash, that's just here on your back. And you'll see here that laboratory values include eosinophil and proteinuria. These laboratory values are really going to help you determine if the patient has the disease. And we'll practice some cases whenever we go through our case practice. As far as treatment, really you want to try to stop the offending agent. And if the patients don't recover after stopping the offending agent, that's whenever you might consider corticosteroids. And that's prednisone, really, 1 mg per kg per day. And again, this is only if creatinine continues to rise after stopping the medications. And then you'll have to taper because we always taper our corticosteroids. So let's do an overview here. So we've confirmed that the patient has an AKI. We performed a renal ultrasound. They didn't have an obstruction. So then we'll calculate our FeNA. The FeNA is greater than 2. So that's what makes us think it's an intrinsic AKI. So what we'll do here is if the patient has a UA that's positive with eosinophils, has a maculopapular rash, or any of the other presentations that we've talked about, we'll assume that's an AIN and eliminate the offending cause and consider steroids. Now, if the patient has an ATN, we can think about it as either ischemic, so that signs and symptoms prolonged prerenal, and we'll treat the prerenal disorder with fluids, knowing that it might take some extra time for the patient to recover. And then if it's ATN due to an exogenous nephrotoxin, we'll discontinue that nephrotoxin and provide supportive care, or do many of the other things that we've talked about as far as treatment. And then for ATNs that are due to rhabdo, we'll give fluids with or without bicarb. In our next section, we'll talk about postrenal disease and obstructions. This is a much shorter section, I promise.